Good evening, everyone. It's Wednesday, March 27th, 2019, and I'm coming to you live from Sacramento, California. And I'm excited to see everybody tonight. Being able to bring a consultation to you is kind of an exciting thing because normally you have to call us on the phone and schedule a time, and now I'm going to come into your world so that you have a chance to hear what a consultation would be like, so that you can say, hey, you've been wondering about midwifery care, go on this Facebook page or Instagram page, Natural Childbirth 101, and pull it up and find out what midwives do. I find that sometimes people are a little shy because they're like, well, I'm really planning to go to the hospital, or I think I might want a birth center birth, and they just aren't sure whether they should go and interview with a midwife. And I say, absolutely. Find a midwife, find 2 or 3 midwives, and schedule a time to go and talk with them, because you're going to learn a tremendous amount. So while we're waiting for everybody to join us, today we have amazing weather here in California. Some of you might be from California, some of you might be from all over the United States, and I have some of you that are outside of the United States over in Europe. And you often don't always see this live as much as you might see it after it's been recorded. But I want to say California is full of rain, and it's full of sunshine, and it's full of clouds today. And when you go out, you see these amazing mountains that we have an incredible amount of snow on right now. So it's been really nice. Our weather is warming up a little bit, and I'm looking forward to spending more time outside. But one thing I learned, and I think it was from REI, which is a sports company, if you will, they said there's no bad weather, there's only bad clothing. So I've tried to take that into heart. All right, so let's dive into what our topic is for tonight. It is a midwife's consultation. So when a family wants to know about our care, they call us up. Sometimes they find us on the internet, sometimes it's word of mouth, sometimes it's on the social medias, and they say, I'd like to schedule a consultation. So all midwives do consultations, and they're always complimentary, so there's not a fee involved, and it's really a time to sit and find out what is midwifery care all about, including what is that particular midwife's character traits all about. And that's where you get an opportunity to find out if you already know you want to have a birth at home, or maybe in a birth center, or sometimes there are certain areas that have midwives that deliver in the hospital. That's few and far between here in the Sacramento area. We do have some hospitals that allow midwives, but it's primarily an HMO type of hospital. Soon, hopefully, again, midwives will be in all hospitals, as that really improves the outcome. It improves more of the normal natural course of birth, and it also is cost savings to everybody involved. But that's a topic for another night. So interviewing a midwife who does home birth. So one of the things that I want you to really understand is that no matter who is pregnant, no matter what the risk factors are at all, you all come to the table with one common ground, and that is that you're carrying a baby. You all want a healthy baby and a healthy mother when all is said and done, right? So everybody has that same goal, and all of you, no matter who you are, go after the same goal. So whether you're planning a home birth, a birth center birth, or a hospital birth, you want, especially if you're looking for natural birth, you all want the same thing, which means that you all have the opportunity to learn the identical same ways, which we've talked about in prior lives, and we will talk about more, of how to go about having a natural birth, no matter what your setting is. But in this particular live tonight, we're going to talk more about the home birth midwife, which is what I am. And I'm going to go through the things that I give as a consultation when a family comes to say, I think we want to have a home birth, or I know we want to have a home birth. And what we want to find out is home birth right for us? Is midwifery care right for us? And is this the particular midwife practice that meets and satisfies what our needs are, both of experience as well as character traits and personalities? So as a midwife in California, and as I said, this is not universal everywhere. In the United States, some states do still not license midwives. There is an illegal in there, so I don't have that. But in California and in many states now in the United States and in many places throughout the world, midwives are the best advocates and the specialists, if you will, at natural birth options. So in California, I am a licensed midwife. That means that I am licensed by the Medical Board of California. That's who currently licenses us in 2019. And I am legal to practice and take care of low-risk women birth givers from the time before they get pregnant, if they want fertility consulting or well woman care, meaning your annual PAPs and gynecology exams, as long as there's not a need for medications or anything. And I begin following women birth givers from the time that they find out that they're pregnant. Families who know us, because we've been in the area for 20 years now, they know that they need to call us immediately when they find out that they're pregnant, because our practice gets full very quickly. But there are lots of midwives in our area and throughout California and throughout the United States and throughout the world to serve all women who choose to want to have their babies at home. So as a licensed midwife, I get to follow women birth givers from the beginning of their pregnancy all the way through until they are 6 weeks postpartum. And I follow not only them, but I also follow their babies. So I work as comprehensive care for them and their babies, both in tummy and out of tummy. Now, it doesn't mean that a newborn might not see a pediatrician in the first 6 weeks, but my care still goes on. So when a woman, a birth giver, finds out that she is pregnant and she calls and she says, I want to come for a consultation. We schedule her for a time and we sit down for approximately about an hour. And it's a very intimate time where it's one-on-one. We're either in our home office or many midwives go out to a family's home, and here are the things that they will let them know. One is what are their legal credentials? Mine is a licensed midwife, and I'm also a certified professional midwife. That means that I have a certification that covers any of the states that recognize certified professional midwives throughout the United States, but not in California. You have to be a licensed midwife. I'm not a nurse midwife, although I used to have a nursing credential, but I am a licensed midwife. So our care is comprehensive. When people come to meet with us, I do all of their prenatal care. I can order their labs if they need or want them. I can order ultrasounds so that they are either routine ultrasounds or diagnostic ones if there's an issue that's going on. I do all their prenatals. They come in each time and usually they get a hug, a big warm smile, and I want to know how their month or their week has been going. Then they go and they check their urine, just like anybody who went to an OB would do. Only I have educated them on what they're looking for on the urine sticks so that they can self-test and help understand what is going on. If something goes out of balance, we do more education. Because I tell families one of my biggest jobs is to be the best educator to you. Because I know I can't create a healthy baby. I can't birth a baby and I can't nurse a baby. That's going to be their job. So the more education that I give them, I love that. Thank you, Amy. The more education that I can give them to be able to take home and create the healthiest pregnancy, birth, baby, breastfeeding, the more empowered, the more ownership the family takes, and the more ability they have to create that healthy mother, healthy baby, right? So when they come in to see me, they're going to check their urine, we're going to do their weight, and they're going to know what those parameters are. If their weight's doing this or this, we get to talk about diet. And nutrition is a key element for midwives at home, because we want you to have the information and the education, and we're evaluating it based on who you are as an individual, what your health is, what your diets are like, what your individual history is, so that we can make the best recommendations for you. Then we hop up, you get your blood pressure taken, your belly gets measured, your baby gets said, hello, I'm so glad you're here today, and did you know I'm so grateful that you're growing so strong and healthy. I love talking to these babies because I believe that they hear us and feel all of that lovely energy that we give to them, and frankly, their mamas or their birth givers appreciate us acknowledging their babies. So I palpate the baby, which means that I'm feeling the baby inside the tummy for how is the water level? What position is the baby in? Is the baby head down? Is the baby head up? How is the baby growing by measurements and by the feel of my hands? How big do I think the baby is estimating to be? And listening for any signs and symptoms and asking questions of anything that's going on with the mother, the birth giver. Does she have headaches? Is there swelling? Is she having leg cramps at night? Is she having constipation? Or maybe she's struggling with an emotional issue that's going on in her life that maybe she needs some direction and guidance, or a journaling, or just compassion and love about what's going on. So we're assessing the physical. Is mom, the birth giver, and the baby growing appropriately, doing all the things that tell us that it's low risk and healthy? And we're building a trusting relationship between us, not only the birth giver, but her partner and her children come. And they get to know us. We get to have the kids come up and tell us what's going on with the baby, listen to the baby like we do. Their partners get to listen, because although we have a Doppler, which is an electronic way like a speaker and a microphone to listen to the baby, we also use a fetoscope, and a fetoscope is like a stethoscope, like you've had listen to your heart. And a fetoscope gives us the ability to listen directly to the baby's heart through the tummy without any external ultrasound or tools. And when we do this, we get to find where the baby is, and we get more connected with it as well. But we always have the Doppler available to us, and we can use both. We love to be able to make sure that iron levels are going well, because with us, we make sure that we check them in the beginning, again at 28 weeks, because women's blood volumes expand and their iron has to catch up with it. So we want to know, where did they bottom at their iron level, and do they need some support to get to birth? We want to see that their glucose is doing well. If they're giving us any symptoms or suggestions or family history that we need to watch over that, we do. But often we're not sending them off to the lab to drink the glucose unless that's what they'd prefer. We often are saying, let's do some checks at home. Let's get a glucose meter. Let's have you look at your diet and write it down, and what your measurement or what your glucose readings are and what your activity level is. And then let's talk about that. Because guess what? The birth giver is the one that can make the changes. So the more insight and information we give to her or they, the better they have the chance of being able to know how to eat in such a way that makes them feel good and helps their baby to not only grow strong and healthy, but in some cases keep at a reasonable size, not too small, not too big, right? Okay, so now we've gone through a prenatal and we make an appointment. We see these wonderful birth givers at the same intervals, once a month in the beginning until 32 weeks, then every 2 weeks until 36, and then once a week until the baby's born. And that doesn't matter if there's something that comes up and a mama or a birth giver is worried about something, then we bring you in, or we come and see you at your house, whatever that may be. So now what happens when we get ready to go to birth? Now that we know that baby's growing well and we know baby's head down and baby is engaged and we're seeing everything that looks well. Now we're also watching for what position the baby's in, and we've talked about that in other lives, how the baby's position can make a difference in how that baby lines up getting ready for birth. So I, as a body worker as well, I'm looking for, is she having sciatica? Is she complaining about her hips? Is she having problems here or there that pelvis might need some help? Get her on a birth ball. Let's move it around, or send her to a chiropractor, massage therapist. Let's keep that pelvis happy and flowing and flexible so that the baby wants to get in a good position, which means the baby's back is up front. Bottom at the top, head in your pelvis, back up front. Baby will do a better job, and so will the power of labor. So we watch for these things as well to encourage a baby to get into the right position before labor begins. So then what happens with labor? Women will say to us, so when do I call? Well, you have access to us 24/7, and you're going to get whoever that midwife is. Sometimes there's 1 or 2 or 3 on a team, but you're going to get them and you're going to be able to talk to them. And they're going to ask you questions to find out whether it's time to come and attend you in labor and birth, or whether it's time to maybe rest, get some food, go in the shower. Just be a little bit patient, because we know if we get to a labor too soon, that a wonderful birth giver is just happy and she's talking and the contraction patterns may be 5 to 8 minutes. If she has to sit around and watch and entertain us, we're there too soon, right? So it is a fine way that we gauge when to go to births. And that's why we keep in contact with a birth giver, so that everybody feels like we come at the time that's appropriate to monitor the baby, because we monitor babies in labor we use our Doppler. Some midwives will use their fetoscope and their Doppler, and we can do that sometimes. Baby started moving just hearing your voice. Oh, that's so sweet, Shayna. Thank you. So we're listening to baby, because if mama's doing well and she's breathing and she's coping and her mind and her body are letting everything come down and open, and she's feeling safe and comfortable, she's taking some sips, maybe she's taking a little nourishment, and she's moving and she's feeling good and her labor is progressing, and we listen to her baby, and her baby is just giving us nice reassuring heart tones, good variability, and everything is going forward. Wonderful. We set up. We say, you are doing fantastic. Keep going. Your baby is coming. We're so happy and excited that your baby is coming. We're going to set up like quiet little fairies in the house, things that we need, but at any moment we're ready. So we begin to set up very quietly. And when we do, we have done a lot of water births, so we make sure the tub is ready. We get lovely warm blankies and towels, and we put them between heating pads so that they're nice and warm for baby and for mom. And then we go in the kitchen, and believe it or not, home birth midwives, we actually boil water. I know, you thought it was only on the shows, but we do actually boil water. And what we do is we make tea. Not tea for us to drink, but we make a wonderful tea for the birth giver for after birth that has some lovely herbs in it that help keep the bleeding minimal. And we make a lovely wash that has a whole lot of wonderful herbs in it for her to use in a little squirt bottle, a peri bottle, on her perineum afterwards to help heal, keep it clean, and to provide lots of good soothing to it. So we get those ready. Then we also get out some safety equipment. Now we have like a little hand, I call it the bucket. It's not really a bucket, it's like a bag. And in our bag we have our gloves, we have the ability to suction babies, although we do them very rarely because babies do a very fine job on their own of clearing all their mucus out. We have suction equipment. We have the ability to release water should we need to. But again, we don't need to do that unless that is something that the labor is asking. so we can release water, so we have an amni hook. We have an ambu bag and baby stethoscope, because those are the tools that we use should a baby come out and say, you know, I could use a little help to help me get my lungs open for the first time, and then I can take over. And there are times when babies need a little help to get their lungs open and flowing, and then they're very happy to tell you all about their story. We keep our blood pressure cuff in order to make sure that mom stays safe, birth giver stays safe afterwards. We're ready for the placenta. We have drugs in our bags. We have Pitocin to use after the baby's born if there is a need for the placenta or for bleeding. We have Methergin, which is another drug used for bleeding issues. We have Cytotec, another drug used for bleeding issues. We carry lidocaine should we need to suture a birth giver. But our goal, and I tell moms, birth givers that way, my job is to protect your bottom. Your job is to catch your baby. Now, my hands are there and I do help, but I really encourage both the mom, the birth giver, and her partner to be as much the welcomers of their babies as possible. And I have found that if a birth giver can get her hands down there with the baby and be actively involved, I feel like it allows their bottoms to open better. They're more willing to their hands instead of being back here someplace. So mine is to help hopefully keep that bottom happy so that afterwards it just wants to stay well and intact. But if it needed sutured, that's my job, to give her a little lidocaine if need be and be able to suture that up for her. The other is to make sure that placenta comes out safely. So in my bucket, I have the medications if I need them, and what I can tell you is in our practice, we throw them away. Rarely do we ever have to use them, but we carry them, and when we need them, we're grateful we have them, we use them, but I carry enough that they go out of date and I have to throw them away, which is a waste, but I'm glad I have them, and I'm glad I don't need to use them, because we're looking for preparation ahead of time also. We want their iron levels to be good. We encourage birth givers to take alfalfa, which builds vitamin K, which helps their clotting factors to do better. We've looked at their labs. We know what their platelet counts are. So we're looking for the prevention of complications. But should there be something come up that nobody could see before, we're there to help the baby, help the mom, and make sure that they both stay safe. Now, sometimes there may be a full bladder that just won't empty, that she just can't pee either before the baby's born or after. And that can cause either a restriction in the baby coming down and birth occurring and dilation happening, or it can make more bleeding afterwards. So I carry a catheter and I can catheterize a woman if I need to do that. So we carry with us even an oxygen tank should mom, birth giver, or baby need it. What we know now is that rarely do newborns need supplemental oxygen, especially at home when we haven't used any medications in labor, they haven't had epidurals, they haven't been pushed further than the capacity that a baby in tummy can do. These babies come out, and with very, 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 very few exceptions, they just need about 3 to 10 extra breaths, and their lungs open, their fluid clears, and the baby is doing well, and their heartbeats are always very good. Now, there's always a rarity, and we're ready for that because we go to neonatal resuscitation classes every 2 years to be recertified. So we have to relearn how to handle a baby should something occur that needs our help or needs stabilizing until the baby can get to extended help. But remember, at home, we are not using all of those extra technologies that can stress a birth giver's body, a birth giver's uterus, and a baby, that creates the need for more watchful technology and the possibility of greater complications, right? So we're giving that differentiation and understanding that natural birth at home, birth center, hospital, you're all going to do the same thing. You're all going to contract, You're all going to open, you're all going to push your baby out, you're all going to receive your babies, and you're all going to put babies to breast. So that is universal amongst all of you, okay? So in a consultation, again, I share with them all of our equipment. The other thing you can see behind me is this happened to be a wall that my midwifery partner, Marlene, began when we were first starting. And way up over there, I don't know if I can tip it, there you go. Way up over there was our first year in 1998. And throughout the years, each one of these is a year. It's weird because it's backwards. Each one of these, how do they do it on green screen when they're doing the weather? That's crazy. So each one of these is a year, and this is our 21st year that we're starting into. And so all of these are the babies that we served in any particular year. And the first one in each one is their year, and then the baby's name, a bead that represents their family or their nursery or something that's unique to them. And then on the top of each one, we chose to put a blue bead or a green bead that signifies whether they were born in the water, on land, and then there are some up there that have purple beads. Now, in our particular practice, in about 100 women, we transfer in approximately 2 to 3 women out of that 100. The majority of the time, it's usually a first-time birth giver who labor just didn't progress well, and we needed now was the right time that her natural birth needed some technology to hopefully get her a nice vaginal birth and or a nice healthy baby with a cesarean. Okay, so that's what the statistics in our practice are. Not all midwives have the same statistics. Part of that can be their locale and the families that they serve and what their individual health and risk factors are. But you can see that the times that midwives transfer is very minimal. And that's why we are able to help a labor. If labor is having a little hard time meandering down the road, we have the ability to be able to say, you know, I think you need to rest, or let's move your hips around, or let's get the baby shifted, or let's do some lunges, let's go up and down the stairs, let's give you something to eat or drink, let's put you in the shower, let's put you in the tub. Ways of helping labor to go forward and build that oxytocin, keep the baby moving forward, and watching over you and knowing when the right time is to take you in, when you and baby are in good shape and technology can be used, and it is a time when it is a positive step in the right direction, right? I want to have another baby just because I miss you. Oh, Bonnie, you're so sweet. Yes, that is a challenge when you bond with your midwives, no matter who they are, is that you feel like you want to have more babies just so you can come and see us. And guess what? You don't have to have a baby to come and see us. So I just want y'all to know that. But part of that is what midwives at home do. We love our families, and we want to help them to feel like they are the only ones, right? Even though they learn very quickly that there are more families that we are serving as well. So what happens once the birth gets ready, once the birth happens? Midwives at home, and especially for us, is I want the pause. I'm a very big proponent of the pause after birth. And that pause, it may be 10 minutes, it might be 30 minutes, it depends on the placenta. And then there's another pause as everybody begins to get acquainted. And what that means is that we give a chance to step back and watch and say, baby's well, mom's well, let them begin to get to know each other, talk to each other, integrate that things have just occurred in their lives. Because that moment of birth is incredibly a transitional time for the baby. Their heart, their lungs, their kidneys, their temperature, their gravity, their brain, their breathing, everything is transitioning in a baby in those first few moments of birth. And then the life of who they are going to live with is going through a huge transition. It's as though time stops in order to allow the time to really integrate who each other are and what's going on. And as a midwife, that's one of the things that's real important to me. Now, my mind is smiling. I'm in heaven watching this incredible experience, but I'm also thinking, do I see any blood? Is the placenta coming? Is everybody safe and well? Is the baby making a transition? Is their color doing well? Because guess what? We actually do APGAR scoring too at home. In our charts, we have our APGAR scoring. It's the same ones that the hospitals do. It's not any different. So we do an APGAR scoring in our head and we chart that down. So we are looking at the health and the well-being of the baby and the birth giver. And so we're waiting for placenta. Placenta, we do not go in and start pulling it out just because it's time. What we are looking for is signs that the placenta is ready to come, that the baby has accomplished its job with it, and that the placenta is starting to come off the wall, which there's some bleeding and there's cord lengthening, and we want to ensure that it comes out in a timely manner and safely. If you go pulling too soon, you can leave a piece in. That's harmful to mom. It's hard on milk supply, and it can cause a lot of extra need of technology later. So midwives want to ensure placenta comes out safely, but that it comes out at the right time. Then we have a baby connected to its placenta, and at that point in time, at some point in time, we want to find out if the parents are ready to do the ceremonial, separate the baby from its placenta. And when they do, we pull out our instruments, because yes, we have instruments, surprise! So many people and medical professionals think that we just go to the birth. That's it. That we have no training, no experience, no equipment, no nothing. And that's why I'm out here telling you we do. We are full scope care, okay? So we usually will clamp the cord and give the partner or whoever is going to do the ceremonial clipping. But the first thing that we do is tell the baby. You're done. We ask the parents, tell the baby about being done with their placenta. And then we say, or I say, thank you, placenta. You served this baby so well, and I'm so grateful that you did such a good job. The baby is safe now. The baby is out, and the mother has the baby, and everything is well. Your job is done. And then whoever's going to cut, they cut the cord. The placenta is in its bowl, and the baby is now completely on its own to be nourished and nurtured and kept warm and safe in the arms of its parents. So the placenta is the next thing. We want to look at it. So at some point in time, within a couple hours, we will have mom, birth giver and baby and partner back in bed. We make sure that bottom looks happy. We will suture it up at some point in time, but that bleeding is under control and that baby gets a chance to initiate breastfeeding, because that is the baby's instinct. Once the baby is done inside and has adjusted for a little bit outside, the baby will start hunting, crying, chewing, wanting, sucking on its hand, licking, because instinctually the baby knows it wants to go to breast. It's phenomenal. So the baby goes to breast, and hopefully the latch takes place fairly quickly. I step back because I believe that the dance between the birth giver and the baby needs a chance. Sometimes too many chiefs in the pot, especially too early, can get in the way. So if there's a frustration, I'm going to come in and I'm going to say, how are things going? Do you need a little bit of suggestion here? Because sometimes maybe it's a tongue tie and the baby's struggling with that, or whatever it may be. Maybe it's just a first baby, and that lovingness of that village midwife needs to encourage a birth giver that they're doing a great job. Maybe we could try this, and encourage them to do it. The one thing that I have a pet peeve on, unless it is absolutely necessary, is that a midwife should never take a breast and latch a baby unless everything else has been tried first. Because that suggests to the mother, the birth giver, that she can't do it. And guess what? The midwife is not going to be there in a few hours, and the birth giver is going to have to breastfeed the baby. So it is important that midwives have hands off, I have a lovely sign that somebody gave to us that says midwives, I can't read it from here, but it basically said midwives know how to sit on their hands and when to use them appropriately, basically, okay? So baby wants to go to breast, so we're encouraging that, and at that point, our eyes and ears are open. We're going to take a blood pressure, make sure mom's doing well, make sure bleeding's under control, baby's color is well, and baby is breathing well. Then the next part is for baby and birth giver and family to have some time while we're kind of tidying up while watching over, and we're going to clean everything up. We're going to clean up the tub. We're going to clean up anything we used in the kitchen. We are going to actually put a load of laundry, no, do not leave us laundry, but the laundry that we've used at the birth, be it sheets, towels, baby blankets, we're going to put those in the wash so that they're started washing. Garbages are going to get taken out from things we've used, and everything's going to be cleaned up before we go home. And the birth giver and her partner will be fed, and maybe there's extra family there fixing food, but we'll fix a nice little snacky meal. And we want to make sure that the baby has nursed well and that we've done a full newborn exam on the baby while we are there. Because doing a full newborn exam on the baby is part of our scope of care. So we're going to weigh the baby. We're going to measure head, chest, tummy, and length. We're going to do reflexes. We're going to check baby to make sure everything looks and feels normal, front, back, and it's a great time to take pictures. Those of you who know me, I'm a big picture taker, so for me, there's lots of pictures that go on, right? And look and see that the baby doesn't tell us anything that the baby might need further evaluation, either by us sooner or to go in and see a pediatrician at some point in time, or that the baby maybe needs to go to the hospital if there's something that's apparent enough that needs to be evaluated in that way. And that's our job, is to know what that baby might need. Then somebody else is going to put the diapers and or clothes if they choose to. We like to encourage a lot of skin to skin for the first day or two. But diapers are a necessity. It's quite messy without them, although we have some that choose not to, but that's rare. So they're going to get diapers on. Baby goes back in usually partner's arms, because now it's time to get the mom, the birth giver, up so that we know she can get to the bathroom, that her head is feeling good, her bleeding is under control, and that she can pee. She gets up, she gets cleaned up, we get lovely little panties with pads on, and we tuck her back in bed, and we give everybody postpartum instructions so that they know what to expect. And we give them in writing, and we give them verbally, and we ask them to call us if they're concerned about anything at all at a moment's time, especially with a baby under a week old, and especially under a day old. So then what do? We go home if they feel comfortable and we feel comfortable that everything is well. And then we're going to come back at 1 day. This is what we do. We come back at 24 hours or 1 day. We come back at 3 days. Whoops, there's 3. When milk comes in, which there's lots of questions and lots of things that are going on. And then we come back at 7 days and we weigh the baby again and we look at everything again. And we're available 24/7 all the way through that. And if there's an issue, either we're going to go back and check on it, or we're going to call in either a lactation specialist. Now, I do most all of our lactation in our practice, but not all midwives do it to the degree that I do. And so they might end up calling someone in like that. Placenta encapsulation. We have somebody that comes in and does that for us. And some people, hire out for that. So then we fill out all the information that goes to the birth certificate office. We have the worksheet. We make sure it's all filled out properly. The family signs it. We either fax it or mail it, depending on the county. And we give them information as to where they're going to come to do that birth certificate, how to go about the things that they need to take with them, and we also give them all the Social Security information and the application so that they know what to take with them to that office, who needs to go, and when to go. And then we see them again at 6 weeks. Sometimes we see them between 1 week and 6 weeks. It depends on the family, the needs, and whether it's a first baby or a 10th baby or whatever it is. So as you can see, Midwifery care at home is very full, comprehensive care. It's safe and it is affordable. Trust me on that one, all right? Now, I had somebody that said, thank you for doing this video. This sets my mind at ease and makes me so excited for my first home birth in November. Congratulations! My last 2 babies were born in the hospital. You did a great job. You had 2 babies already, and that means a baby who's a 3rd baby coming at home is going to be such a wonderful experience for you. In fact, your partner's going to say to you, that was so easy. Now, you're going to look at your partner and say, hey, that was still a big job for me. But the ease of it and the sweetness and being so well cared for and given so much information and knowing that it is so incredibly safe, because guess what? Hospitals are open 24/7, 365 days a year, and like any other time in our life, if we need them, we can go. Birth is meant to be normal. There are things that need to help create it to be normal if there are any challenges, and midwives know how to do that. Herbs, nutrition, journaling, exercises, even sometimes having someone else evaluate you in the medical community to make sure you're still a good candidate. Now, I want you to start thinking about your questions. If you have questions for me, I'm super excited to answer them, but these are kind of the things that start out. And some of our families that come in, they'll say, well, what have you transferred in for before? Or what kind of complications have you dealt with before? Or can you do a breech? Can you do twins? Can you, how early can you do a baby? How late can you do a baby? So start feeding me off some questions and get your thumbs busy typing in there. And I just want to say hi to Amy. Hi, Amy. I love seeing you come up here. You're fun. I find you in all different places, which is fun. And hey, Danielle. Some on the Instagrams, I don't know who everybody is, only because your signature names I may not know. But I want you all to know that I am so grateful that you tuned in tonight, because this is the beginning of what this road starts. And the more that we can get this one shared, the more people have access. And I'm one of thousands of midwives, okay? In California, hundreds of midwives, but thousands of midwives throughout the United States and throughout the world. And yes, we're all a little bit different, but here's who we are. Thanks for the little hearts. I do love those. Those are very fun. All right, so as I'm waiting for your questions, I'll go over some of those things I just said, all right? Why would we transfer in? Because that's usually one of the things. It's either, especially for partners, they want to know how much does it cost and is it really safe, right? Yeah. Okay. So the reason that they want that is that they want to make sure that the birth giver and the baby are going to be safe. And that's their job. And cost is another issue. Now, I can tell you about the, I can tell you about California and Sacramento area. On the whole, in California, the cost is somewhere between $5,000 and approximately $8,000, depending on where you live. Many midwives have a Medi-Cal rate if you're on Medi-Cal and need to pay cash. Some midwives in the state of California can bill Medi-Cal, although there's very few. Birth centers are more likely to be able to bill Medi-Cal because of what Medi-Cal pays. And if you are a Medi-Cal mom, just look for all your options, and all of us generally will take payment plans. And the key is just to keep up on the payment plans and make sure that things happen. Some families have to get gifts for their showers instead of getting baby gifts. They want checks to help pay for the midwifery care, and some insurances will compensate for a partial amount of the fee for home birth midwifery. So hopefully that answers that one. And never underestimate that you can make it happen, okay? Why else do we transfer in is Number one, the majority of the time that we transfer into the hospital is because we have a first-time birth giver and labor is not progressing in a way that we can seem to get there with it, with herbs, homeopathy, movement, rest, foods, fluids, warmth, patience, time, whatever it is. We just feel like we have done what we can do at home. Now it's the most appropriate time to transfer in and get a little bit of technology, hopefully, to help get this labor forward and a baby in their arms so that the baby is healthy and is excited to be here and everything goes well postpartum and during the birth. But if need be, and a cesarean is necessary, then that will occur. And our job is we're going to stay with you. And we're going to stay until that baby is back in your arms and at the breast and we know it's safe to go home. And personally, I go back to the hospital at 1 day and I continue my care. I go back at 1 day, 3 days, and 7 days, regardless of where the family is. Why? Because midwifery care doesn't stop. Midwifery care keeps going. And it's not just that the docs have now done the delivery. They have their job, they have their strengths, and they're very good at drugs, medication, testing, and surgery, and high risk. That's really their specialty, and I'm so grateful that they're there, and when we need them, I'm so grateful to go in and have them help take over and walk with us through that journey to get a good, healthy baby and mom. Okay, so what other reasons would we transfer in? Once in a very, very blue moon, there's a placenta that won't come out. Going through the 20 years, we've gained enough insight that we've had a very rare situation that we've ever had to transfer somebody in since many, many years ago that had a placenta that didn't want to come out. But that is one reason that some midwives might transfer in. It's because the placenta won't come out, and that may need some help. Have we done VBACs at home, meaning a vaginal birth after cesarean, which is what I talked about last week? Absolutely, I've done VBACs at home. Sometimes the same scenario might happen again, and that's why we go in, because the baby wasn't going to come out at home the first time, and it wasn't going to come out the second time, even with midwifery care. It was the best that a mom could do would be to labor up to that cesarean at that point. Let's see. Other reasons why we transfer in. Every once in a great while, a baby, can you do a home birth if you are GBS positive? Great question, Joe. I am going to answer that one. Every once in a great while, I have a baby who's just not making the transition to outside life like I would like it to, and with what I understand, having been a pediatric nurse and various things, I say to the family, I think this baby is going to need a little more oxygen than what we can do here at home, and it may need just a couple of days of sort of drying out their lungs before they're kind of transitioned the way that we want them to. And we go in private car. I mean, it's so rare that I've ever called an ambulance to take somebody in. Not to say that that doesn't happen with midwives sometimes because of an issue, but that could happen. If they had a significant amount of meconium where the baby pooped in the water, and I felt that it was more than I wanted to have this baby have to handle, or that the baby was telling us there's a reason for that, so let's go in while the baby is still in good shape, so that if the baby needed more help afterwards, which I wouldn't anticipate that it would, but if it did, it was in the right place to get that extra help. So one of our subscribers said, can we do a home birth if you're GBS positive? Absolutely. So if you happen to get a test at roughly 35 weeks, which is a swab, and you come up GBS, which means group beta strep positive, this means that you are colonizing. It does not mean that there is an active infection, and this is one of the things that women really, really need to be clear about. This does not mean you are infected. It means you colonize more of group beta strep in your vagina, and it comes from the bowel and sometimes crawls its way up in there. So if a woman, a birth giver, tests positive, we have a natural protocol that we use, that we offer to her. We say, here are your choices. 1, you can go to a hospital and deliver and be on antibiotics if that is where you feel safe. The families in our practice are like, no. But I say, but you have to know that's your option. 2nd, you can have antibiotics at home. We are not a practice that carries antibiotics and runs IVs. So I tell them we would have to contact one of the other practices that does put IVs in and does put antibiotics in to come and administer that to you. That's an option. The other thing is to use our natural protocol, and we've had good success with that, which means that they use various washes and they take certain supplements to help make sure that their body is as good on the immune system and that their vaginal canal is rinsed well, so that hopefully it builds good bacteria in there, and that we're not using antibiotics to sterilize the field, which we also know can be a problem for the baby and their microbiome for life. We know that the use of antibiotics, when there's a roughly 40% of most birth givers are GBS positive, and they're all getting antibiotics in labor who deliver in a hospital setting, and many may be at home, that can set them on a path for having yeast infections, both vaginally and on their nipples and thrush in the baby's mouth, and it does sterilize to some extent the microbiome of the newborn, and research is now catching up that this is a problem for newborns. So for me, I like to minimize that risk, but the most important thing is that a birth giver is educated and they make the decision that is best for them as long as they have those recommendations. So can you deliver at home? Absolutely. Are there a few things that we take into account? If you are GBS positive, yes. And that is if your membranes rupture and you don't go into spontaneous labor within 18 to 24 hours, we want to start pushing that labor because we don't want the risk that maybe an active infection could start. The other thing that GBS, if you look at it, is what the United Kingdom's protocols are risk factors. If somebody has had a baby who was sick with GBS in the past and is also GBS positive, we do care for them in a much different way. But I'm not going to go into all of that tonight. So great question. Yes, you can. Not a problem. All right, more questions. Asking from Ontario. Well, hello. Are you integrated into the hospital team? No, Ontario, I'm assuming that you're in Canada. And up there, I think, I don't know for sure, but you have the capacity to kind of go home and hospital. Here in California, although our law allows us, by law, we could practice in a hospital, we do not have a system that integrates licensed midwives into the hospital staff and ability to deliver in the hospital, primarily because we are not on socialized medicine, is my guess, and also because of malpractice issues with that. So that was a great question, and no. So when we go in, we're really the advocate for the family, and we hope that we can integrate with the physicians and them to tell them what's going on, give them our records, and be a good advocate of encouraging the family that if a technology is recommended, that we can say to them, because we're the ones that they're trusting, that's a good idea, this is appropriate for now, I know you wanted a natural birth, but that's kind of why we're here, is to get some of this technology now. So no, we are not integrated into the hospital team. Someday, we're hoping we can, because some midwives would like to be able to transfer over like that and have that opportunity and not have to have the family totally separate in the type of care. All right, let's see. I mentioned to you other things that we can handle at home. We are all taught to handle shoulder dystocia. So families say, well, what if the baby got stuck? I say that's part of our job, is to know how to help that. And if a baby has a shoulder dystocia and you are not on an epidural, you can move. And we're taught how to help babies get out, how to turn, how to move, how to help a baby to come out in that way. We're also taught and some midwives are experienced in doing breech deliveries, but in California, we cannot, by law, attend a breech delivery at home that's known. I mean, if one pops out at the last second and we happen to be there and we didn't know and we walked in the door, well, of course that's going to happen. But our job is to be good palpators to make sure that we don't get into that position in the first place. But we can't do breeches. We cannot do twins at home. That was in 2014 that the law passed. It was implemented in 2015 so that we can do babies who are only head down, singletons, who are 37 to 42 weeks. So a 42 week or over, they would have to be transferred out of care. But again, I've talked about that in other lives, that we have lots of ways of helping to ripen women, birth givers, should they want that, which the majority do, to be able to help get the baby born without having to transfer them for an induction. And knowing that if we can get everything going at home, and I can say in our practice alone, we have been successful with that. I think we've had one mom that was way back in early time that we could not get her labor established, and she did transfer in. And we had one other mom who 3 different times with 3 different midwives planned a home birth, and all 3 times her labor would not go forward. And so for her, she was a unique mom with a good home birth natural heart that needed to have her baby by cesarean each time. All right, let's see if there's more questions. I think it's about to tell me that I have about 3 minutes left. So we're going to be getting close to ending here soon. So resuscitating a baby, shoulder dystocia. If a breech showed up unexpectedly, we would either transfer over, or if there was no time, we would manage what we needed to and take care of that, because we are trained to do breeches. And as I said, some of us have done breeches before the law changed. But our goal is, as I love one of our wonderful midwives in our community, get the baby to turn. Don't just leave it there, right? So there are different ways of helping to get a breech baby to want to turn with acupuncture and chiropractic and massage and slant boards and moxibustion and homeopathics and all the different things that we know about to encourage a baby to get into a head down position so that we don't have to worry about transferring a birth giver who has a breech out of care. And if there was a bleeding, we handle that. We've got the drugs. If there's if there's a tear, we suture it. We can handle it. If the bladder's too full, we can do a catheter. We can handle full care, with the exception of vacuuming. We would never do that with a baby, to vacuum a baby out, forcep a baby out, hang Pitocin in labor. We would never do any of those. Labor has to go forward under natural means. And afterwards, yes, we can use drugs for bleeding, but we don't do epidurals or anything at home. I had an anesthesiologist actually ask me that one time. He said, "So can you do epidurals at home?" And I said, "No, we're not anesthesiologists. We're natural." We want birth to go forward under its own power, right? That's what we do. And our job is to watch over and ensure that everything is going well. So I've had a delightful time tonight. Thank you so much for coming by. So go in, hug those cute little babes that you have, and I don't care how big or how old they are, how tiny they are, even if you have to give them a little finger hug. But tell them you love them. Tell them how amazing they are. And tell them that they can do anything that they set their mind to. And please go back and see this on my feed and push share to as many as you possibly can so that they get to find out, what do midwives do? All right, thank you so much. I'll see you next Wednesday. Bye for now. And next Wednesday, I'm going to have a new midwife and a brand new student midwife who's coming, and we're going to interview and we're going to talk about that. So bring all your friends. Okay, bye for now.